Hello, everyone. My name is Danielle Rahajasan, and on behalf of the National Center for Medical Legal Partnership and our panelists, I wanted to thank you for taking time out of your very busy schedules to attend this event today. We are very excited to see you again and welcome you to the second session of a four-part learning collaborative titled Using Legal Services as Part of a Community Strategy to Improve Maternal Health in Health Centers, especially this month as we honor Women's Month and today specifically, which is International Women's Day. As we do this work of empowering our communities and bettering the health of women every day, today we are reminded that there is still a lot of work to be done, but that we have power in our unity and in our voice in shaping community health and leading change. Next slide, please. In just a moment, I'll turn this presentation over to our speaker. But before that, I have a few small housekeeping things that I would like to run through with everyone. Everyone joined in on mute. However, we do encourage you to unmute yourselves throughout the webinar, throughout the Learning Collaborative. We are using Zoom for our event today. If you have questions, please type and send those through the chat function so that panelists can see them and engage with you. If you would like to activate captions, please select captions and show captions on your toolbar, which should appear at the bottom of your screen. And yes, today's audio recording and slides will be made available to all participants in a follow-up email that should go out by next week, so look out for that. Next slide, please. We also want to acknowledge that this project is made possible with the generous support of the Health Resources and Services Administration, and that the contents are those of the authors and do not necessarily represent the views of HRSA. Next slide, please. So like I mentioned in my initial introduction and in session one, for those of you who could not attend that session, this is a four-part learning collaborative that focuses on how the medical legal partnership approach can align with health center priorities or your organization's priorities to help improve maternal health in our communities. Last year, some of you may have attended our first edition of this collaborative that focused on both maternal and child health. And this year, we will really be focusing our energy on exploring strategies to integrate legal services as part of your clinical practice to address maternal, social, and legal needs. The sessions are all 90-minute long and will include short didactic sections coupled with guided discussions in the form of breakouts or other methods. This cohort will meet every Wednesday in March, and we started in March 1st, and today's the 8th, and so the next session will be March 15th, and the last one will be on March 22nd. During every session, participants will hear from faculty as they discuss their MLP models and share learning around strategies from their own successes and challenges when developing a maternal health-focused MLP. Panelists will also help us moderate discussion questions, and we really, really encourage you to engage during those discussions and share your successes and challenges with each other, as well as the panelists and us here at NCMLP as well. We do know that we have a mixed cohort here in terms of organization types or MLP familiarity. So there is something here for everyone as this collaborative will meet you where you are. Please don't hesitate to ask any questions and share any ideas and practices. We shared some discussion questions with everyone through a follow-up email, I think, that went out yesterday. So hopefully you're all able to get a quick glance at that to start a discussion today. Next session, please. Next slide, sorry. So for today's agenda, we'll look at the collaborative objectives really quickly. I'll introduce our speaker for today, and we'll hear from her as she has prepared pertinent and useful content and resources for everyone. Then we'll go into the guided discussion and close out. So next, through this collaborative, our objectives are to make sure that participants will understand MLPs and their role in maternal health, understand how to detect and address unmet legal needs that negatively impact maternal health outcomes, and also be able to develop strategies to collaborate across health and legal settings with your organization's maternal health priorities. Next slide, please. So as you know, we are joined by an amazing group of experts on this learning collaborative, and by now you should be slightly familiar with these faces, but you'll get to know them a lot more throughout the collaborative. You also should have received a welcome packet that was sent to you before March 1st. By the NCMLP team. If you haven't, please let us know in the chat so we can make sure to get that into your inboxes. If you want to learn more about these individuals, please consult that welcome packet as well as their websites. So very quickly in session 1, we were joined by Amanda Elkinnick and Bronwyn Blake from Texas Advocacy Project. Today's session will be led by Courtney Mendoza from Mental Health Advocacy Services. Session 3 will be led by Nola Booth from Legal Assistance of Western New York, or Law New York, and then some familiar faces from last year's collaborative, Vicky Gerard, Laurel Patchen, and Roxana Richardson from Georgetown University's Health Justice Alliance will lead session 4. Next slide, please. Before we begin, I want to make sure that we get to know this cohort of learners. So if you can use the chat function to write in your name, title, organization that you work for, as well as its location, so mainly the state, and also answer the question, what is your one major takeaway from session 1? As I level set with everyone a little bit and share highlights from that session. Next slide, please. So very quickly in session 1, you heard from our guest speakers, John Richards from National Center for Education in Maternal and Child Health at Georgetown University, who shared resources such as the White House Blueprint for addressing the maternal health crisis. He also discussed the work BIPIC, or the Bureau of Primary Healthcare, does to support health centers' maternal and child health efforts, and also talked a little bit about how Title V assists pregnant women. He also discussed the importance of data when thinking about strategies that impact change in all 15 national performance measures areas. We then heard from Laurel Patchen from Health Justice Alliance at Georgetown University, who briefly talked about the impact their maternal health MLP has had, particularly on removing the fear within clinical teams of asking the hard questions around context that matters for health outcomes. Finally, we heard from our panelists, Amanda Elkinnick-Oder and Bronwyn Blake from Texas Advocacy Project, as they talked about their maternal health MLP serving people who are experiencing interpersonal violence and its impact on the maternal health of the communities they serve. We do encourage everyone who could not make it to session 1 to review the recording that was shared with all participants yesterday, as a lot of great resources were shared with the audience as well. And next slide, please. And so without further ado, I will pass it on to Courtney Mendoza, who is the staff attorney at Mental Health Advocacy Services in California, to talk about her mental health MLP model. Courtney, all yours.
Hello, everyone. Thank you for that wonderful introduction, Danielle. I'm Courtney Mendoza from Mental Health Advocacy Services, and I'll be talking about our maternal mental health medical legal partnership. So I'm going to share my slides, and I just want to say our medical legal partnership is relatively new. It's been going on for 2 years, so although I'm presenting, I very much welcome questions, tips, suggestions. As much as you all are here to learn, I am as well. Okay. All right, and can you all see these slides well?
We can see them, Courtney.
All right, thank you. So to give an overview of our project, so Mental Health Advocacy Services is the legal aid office that I work at. They're my host organization in Los Angeles. We created this medical legal partnership through an Equal Justice Works Fellowship, which I'll discuss as we go through this presentation. And our medical partners in this project are the Nurse Family Partnership. So Mental Health Advocacy Services, or MHAS, which I'll be referring to because it's a mouthful, our organization started in the 70s, sort of during the time where a lot of reform was happening in insane asylums and sort of the advocating for more humane treatment for people with mental health disabilities and destigmatizing mental illness. And so since then, we've sort of served as the legal aid expert in Los Angeles County for clients with mental health disabilities. And so other legal aid offices who might encounter a client with mental health disabilities with, perhaps challenging behaviors that make advocacy and assistance difficult will often refer them to our office because we have sort of that skill set and that trauma-informed knowledge of working with clients who may be experiencing mental health disabilities. And so we're a generalist office, which means we handle a little bit of everything. We know a little bit of everything. So we have a wide range of civil legal issue areas that we serve, from housing, public benefits like food stamps, or CalWORKS, which is California's Temporary Assistance for Needy Families program, re-entry, so things like criminal record expungements, special education, and more. And the great thing about MHAS is that prior to me joining the office, we had already been part of LA County's countywide medical legal partnership. And this is a program that actually started through an Equal Justice Works Fellowship in the earlier 2000s, maybe 2010s. And this countywide project operates at health clinics and hospitals across the county. It was originally funded through the Department of Health Services by the county. And now sort of a group of legal aid organizations are staffing these different sites. So at LAC USC Hospital in South LA, we have, one or two attorneys at that center. So this is a successful medical legal partnership that MHAS has been a part of. And that was really helpful for us to sort of mimic when we were creating our maternal medical legal partnership. And recently, with this countywide program, and I know you all have funding questions, so we'll get into that later in this presentation, but recently our funding for this countywide program has changed through being funded by the Department of Mental Health, which provides a lot more long-term funding, more stable funding. So we're hopeful with this change in funding. And also the program is expanding to mental health clinics. So not only are we staffing, hospitals that typically only serve physical healthcare. Now I'm actually in a mental health clinic today, piloting our mental health medical legal partnership expansion. So I'm all about medical legal partnership. And to get more into our maternal medical legal partnership, our medical partners are the Nurse Family Partnership. And this is a program that originated also in the 70s in New York. And this is a nationwide program. So there are branches in New York, across the country, and the specific branch we partnered with was the Nurse Family Partnership in Los Angeles County. And this program, what they do is they serve high-risk, low-income, pregnant or postpartum people living in poverty. So it's a free service, it's voluntary. And the great thing is that it's a home visitation program that follows clients over the course of 2 years. So whether they meet the patient, in the third trimester, first trimester, they'll stay with that patient for the course of 2 years, providing prenatal, postpartum care, and now in LA County, legal assistance. And so a little bit about this medical program. It started off small, it's expanded. So now across the county, there are about maybe 10 to 15 mental health therapists in the program, and tons more nurses involved. But as far as our maternal mental health medical legal partnership, we've been getting referrals from the mental health therapists in this program. And so this program is funded with a myriad of different grants, which is not uncommon for health centers and medical legal partnerships. So both county, state, and some federal funds. And the beauty of partnering with this program and sort of the design behind our maternal mental health medical legal partnership was the home visitation aspect. So especially for a maternal client population, we recognize that time is precious, resources are precious. So it can be difficult for people who are high risk and low income to take time off of work, to get transportation, to get childcare, to go to their health appointments or go to an attorney's office. So we really liked this idea of partnering with a home visitation program, which we hadn't really done in Los Angeles County prior to this project. And then we were developing this project in 2019, and it got approved in March of 2020. So sort of the bright side of the pandemic was that our project was already set up to adapt to the pandemic, and even more so, our project, the need increased by the time that we started, serving clients. And so before I get more into how we developed the project, how we started it, how it's been going, I wanted to put out there to see what types of service delivery models you all utilize in your medical legal partnerships, or that you hope to utilize if you're trying to start a medical legal partnership. So feel free to unmute or put in the chat sort of what service delivery models you've been using.
Can everyone hear me? Hi, my name is Laura Mutri. I'm a hospital pediatrician at Dornbecker Children's Hospital in Portland, and our medical legal partnership is fully integrated into the hospital. So we are in person, and then right now our program is just in our NICU and fetal therapy programs. So once we get to know families, we're able to meet with them virtually. And then we're also trying to partner with our pediatric home visitation program here. So we really try to meet people where they are.
Amazing. Yeah. So a hybrid delivery service model, which I think that flexibility, especially for maternal populations, that's everything. As much as I was tooting my own horn about the home visitation benefits, it really is, being able to meet people where they are, whether it's at site, virtually, in the home, is very important.
Courtney, I don't know if you can see in the chat, there were some responses. Some are using a doula program, Pathways Hub, and Holly Gasper was sharing that they're using a family resource center with nurse home visiting model as well. I don't know if any of you would like to share further.
All right. Well, thank you for that. Again, oh, go ahead, Mary Curry.
Thanks. We have an FQHC in our area, but we haven't been able to come together and identify funding, even though obviously we can use some of the HRSA dollars for it. We haven't made that come together yet, but we are serving some of those clients through other avenues. The Pathways Hub is a model that's kind of taken hold in Ohio, and it's not. It doesn't have some of the advantages of being embedded in a health center, but it has some other advantages in terms of having access to a lot of well, I guess spokes on the wheel for additional services. So it's been interesting to have that alongside our more traditional, I guess, medical legal partnership with the Children's Hospital, for example.
Awesome. Yes. And we'll definitely get back into your comments about funding and not quite, getting to those dollars yet. All right. So now that I know a little bit of how you all are delivering your services, I want to gear back more towards this funding issue that we've all been experiencing, all been concerned about. Oops. And so our maternal mental health medical legal partnership was originally funded through an Equal Justice Works Fellowship. And this is a type of postgraduate legal fellowship. And it provides funding over the course of 2 years. So the idea of this particular postgraduate fellowship is to identify an area of unmet need, figure out a project that will serve that unmet need. And then the goal for all these fellowships is to sustain it beyond the 2 years of funding. And that's always the hardest part, right? But the cool thing about Equal Justice Works Fellowships is that they have funded about 63 medical legal partnerships to date since their inception. But a lot of these medical legal partnerships are not focused on maternal populations. And even if they are, even fewer are focused on maternal mental health. And that's sort of our angle with our project because, considering mental health in a medical legal partnership, I think is very important, especially when we're talking about social determinants of health. And so another good thing about this Equal Justice Works Fellowship is they don't consider law school GPA. So I know there's some attorneys in this presentation, so you may be more familiar, or, if you're considering someone that you know or an intern that you worked with, this fellowship project does not focus on that. They rather focus on the passion for public interest law that applicants have. So the goal of Equal Justice Works is to foster people to go into legal aid careers without worrying about, the pay scale, very different from law firms and all of that. And I always tell people with this type of fellowship, they look for the right person, the right project, at the right host organization. So they want to make sure the person working on this project, their heart's in it, the project makes sense for the area of unmet need they're looking for, and their host organization is equipped and has expertise in that area of unmet need. And not only this, but they do pay your student loans over the course of the 2 years. So I have been, the past 2 years were very good to me. Myself and Mental Health Advocacy Services, my host organization, we developed this project to help address the social determinants of health for pregnant and postpartum people in Los Angeles County. And specifically in Los Angeles County, we really wanted to work toward ameliorating the disparate rates of maternal infant mortality, preterm births, and other factors of health harming legal issues, specifically for Black and Latina mothers in Los Angeles County. And so in my application, when we were submitting this fellowship project, and also let me backtrack, when you apply for an Equal Justice Works Fellowship, it's kind of like Shark Tank. So, you create this application, Equal Justice Works reviews it, pulls out the ones that they like, and then they distribute it to a group of funders that are connected with Equal Justice Works because they're looking to fund projects. So those funders range from law firms, corporations, to individuals. And so I had the pleasure of going on 3 different funding interviews with all those 3 different types of funders before we were finally approved and we got our funding. And so this was the data that I presented when we were pitching our project and explaining the needs. So in Los Angeles County, these are data points from 2010 to 2019. And this is for maternal mortality rates. And you can see that the section for African-American or Black mothers is significantly higher than any other racial group. And the section for Hispanic mothers has been increasing over the years. And this is the most updated data that the county has released so far. So we were lucky in terms of our application that, you know, they had released this data up through 2019, which is when we were applying. But this can be a limitation, you know, when you're trying to find data to prove your unmet need and establish your medical legal partnership. If the data is not there, it can be difficult. And this is more data from LA County. This is the infant mortality rate. Again, the rates for African-American Black mothers significantly higher, with the rates for Hispanic mothers just below. And then again, for preterm births, the same data trend follows. And so with this, you know, there is a need, not only in LA County, but this data kind of reflects what's going on across the country. And you know, not only due to issues in the healthcare system as far as dismissing or minimizing, you know, Black or Latina mothers' pain or complaints, but all these other social determinants of health. So we recognize that our maternal mental health medical legal partnership is not going to solve this, but we're going to, you know, there is this need, so we should try. And then this is a recent article from the USC Health Journal in October 2022. And it coins the term weathering, which is similar to kind of the idea of social determinants of health that was touched on in session 1. But it really just illustrates, you know, the stress response and how that causes physical and mental effects on a mother, and how that can affect infant maternal mortality, preterm births, and so on. And then specifically in LA County, you know, we cite to the housing crisis, which is disproportionately affecting African-American Black population in LA County, despite, you know, the actual percent of the population they make up. And we also touch on the racial biases in the healthcare system. And so to bring it all together and tie on why I think we received this Equal Justice Works Fellowship. It is a competitive application process, but again, right person, right project, right host organization. So this is a picture of me. I look very different, but this was I graduated law school in 2020. And this is a picture of me at our ceremony in 2021, after it was safe to have it. And my being, you know, quote, the right person for this project, I went into law school knowing that I wanted to help families similar to mine, but also recognizing that I had privileges growing up that not many families do. So I was raised by a single mother. She was raising 4 children on her own, and she worked 2 full-time jobs as a nurse. So she worked in the day and then worked during night. So we didn't see her much, but these were the circumstances we were facing. My parents divorced when I was very young, due to my father dealing with his own journey with his severe mental health diagnosis. And so, you know, while my mother was struggling physically and mentally with that toll of being a single parent, my father was going through his own journey of experiencing low income, experiencing homelessness, and even incarceration, which is not uncommon for a lot of people with mental health disabilities without resources and without support. So, you know, growing up, I did not have this wisdom, but going into law school, you know, I recognize how mental health can affect the entire family, and it can affect development, and, you know, not only for the parent with the mental health diagnosis, but also for the other parents and for the children. So I really wanted to use my law school degree to do something along those lines. I also considered psychology, but decided to go the law school route instead. And so before we get more into this project, how it's going, I wanted to see if any of you all have utilized an Equal Justice Works Fellowship at your organization, or other types of postgraduate fellowships, legal or non-legal, to get funding, initial funding to pilot new projects.
Courtney, I'll unmute and chime in because several of us on here are either Equal Justice Works fellows or alumni. And the National Center for Medical Legal Partnership does count Equal Justice Works as a very long time MLP supporter of the movement. And we consider the fellowship a critically important part of the funding strategy for MLPs. So if anyone on here has utilized an Equal Justice Works fellow, in addition to answering Courtney's question about whether or not you have done so, it would be helpful to know, what are some of the challenges that you may have faced? Those of us who have served in the fellowship or even run programs that include the fellowship, because I still work there as well, we know it's a 2-year program. And so part of the journey in having a fellow is that you have to search for funding as well to be able to continue either the fellowship or, there's the recurrent effect of having to staff the fellowship with a new fellow again. So what are some of the, challenges or successes that you've seen with regard to having an Equal Justice Works fellow as a part of your strategy? That's as much as I will insert for that. I would love to hear from folks. And again, Courtney, you're welcome to also call on people. In the chat, we see Marie and Socorro. Socorro, Marie has had Equal Justice Works fellows. The first 2 FTEs were for the MLP were Equal Justice Works fellow, and Socorro has not. Socorro, do you want to provide any remarks live to talk about your familiarity with the fellowship or any concerns or challenges you may have had in terms of recruiting a fellow? And Socorro's typing, she's not familiar with the fellowship yet. Okay, it's good. That's actually really good to know. And we'll, at the National Center, help plug some more information. Courtney, you're doing some really helpful advertising here. And in addition to sharing really important information about funding strategies that people can take advantage of. So the NCMLP team will plug a link in the chat to our NCMLP toolkit, because in there, I believe we have a budget chart. And Courtney, I think it does still include Equal Justice Works fellows as a part of the fundraising chart. So we'll plug that. Appreciate folks sharing as well in the chat. Okay, going back on mute.
Awesome. Yeah, I'm happy to see that this is new information to some of you all and that you'll look into it, because I am biased because I am a fellow and I have been hired on as staff at my organization since then. But I'm not funded by them anymore. So this is free advertising. I really do think highly of Equal Justice Works fellowships. And the search for funding to sustain a project is universal. It's not limited to fellowships. So it's sort of a challenge that we face always as nonprofits or as health centers. And so I know in session 1, we talked a lot about social determinants of health. And for those of you who weren't able to make it to session 1, the idea of a medical legal partnership is, say, a child has asthma or gets pneumonia because of mold in the household that the landlord's refusing to fix. The doctors can only treat it so much, but with legal intervention, that's sort of the idea of this medical legal partnership model. So this infographic is from the National Center for Medical Legal Partnership, but I wanted to put sort of a mental health spin on it. And similar to physical disabilities, with mental health disabilities, it can be very difficult for people to continue working, maintain employment, and this will affect their ability to pay rent, can increase their chances of experiencing homelessness. And then at least in LA County, you know, there's a lot of homeless citations people can get for sleeping in their car, sleeping on the sidewalk. And then that whole cycle, you know, now they have a record, which will prevent them from getting a job and getting housing again. So this cycle of social determinants of health is just as pertinent for mental health disabilities as it is with physical disabilities. And so how our maternal mental health medical legal partnership actually works in practice is that before we even started, I met with the nurse family partnership and the referring providers who are the mental health therapists in the program. And I gave them sort of a legal training, not expecting them to become attorneys or issue spots, you know, things that should be appealed or, you know, this is a case, nothing like that. And the idea of this was we did not want to increase workload for medical providers. We know there's already a ton on their plate. We really want this to be a convenient, useful service for the clients and make it work for both medical and legal involved. And so I gave them a legal training just so that they know, okay, food stamps issues, that's something Courtney can help with. You know, immigration questions, MHOS does not take on those cases, but Courtney can still give advice, counsel, and referrals for those. So just letting them know what I serve with so that when they meet their patients in their homes or virtually during the pandemic, they can recognize that and send the referral form. So I created a referral form, which I'll show in the next slide. And all the provider does is give me the client's information, send that to me, and then I contact the client. So in order to maintain attorney-client confidentiality, we sort of work separately, but unless the client consents or it's necessary for us to share and collaborate more closely, we can do that. But again, to sort of keep everyone's workloads the same, not increase anyone's, you know, put a burden with the implementation of this program. We sort of work separately unless it's necessary to collaborate more closely. And so this is the referral form that I created. And mind you, this was created by a law school student who is about to graduate. So it is by no means perfect, but we actually haven't made any adjustments to it over the course of the 2 years. Because one, we wanted to keep it simple for referring providers. And two, actually one of the best things I found that we included on this form were best time to contact, and then of course, preferred language. And I think this best time to contact section is important, especially for maternal populations, because, you know, I'm not trying to be the one calling them during their baby's sleep schedule, or maybe they're at work during this time. And if I keep calling them then and I never reach them, I'll close their intake and they'll never get assistance. So this is very important, I think. Depending on what other delivery service models you have, I still think it's important to gather, because not only that, it shows the providers and the clients that an attorney is mindful of their schedules, and especially with all the, I would say, negative stigma lawyers get on TV, which is well-deserved sometimes. I think that's very important in medical legal partnerships. I know some of you noted some clients have concerns with getting attorneys involved, which is understandable. And so that's part of why I did the legal trainings with my referring providers, so that they could see me, could see that I'm not intimidating, and they would be comfortable referring their patients to me and have them speak with me. And another thing I developed for this project were pre and post intervention surveys. And so again, these are very rudimentary. This did not have a legal server system at this time, so we were still using just paper documentation of things. But I basically reflected what we now collect through our online service system, demographic data, but also on the right side, having clients self-rate their physical, mental health, that of their children, and then their knowledge on different legal topics. So this is the first survey that I administer to clients the first time we speak. And then the idea is that it's followed up by this post-intervention survey when I close their intake or close their case. So I'll ask them the same questions again. And yes, these are self-rating surveys, and I'm, talking to the client on the phone, asking them this. So there is, it's not perfect data, but some data is better than no data. And that's really proven successful with our project, because even with the rudimental resources we had, me being the only attorney on this project and presenting the self-rated data that could be very biased with clients reporting to me how they feel about my services, it has gotten us funding to continue this project today. So, you know, I would encourage you all to not be hesitant to just start a project, or, you know, go with what you have, because you can always improve it, and at least you'll have something to show, and you'll learn from what data you're missing or what you can improve on. And so as far as the legal areas our maternal medical legal partnership has served in, it reflects what our office practices generally. So housing, public benefits, expungement, special education, and for areas of family law and immigration law, we do not have expertise and we don't take on those cases, but especially in LA County, we get tons of questions on those. So we have advice, counsel, self-help resources, and legal aid referrals to immigration legal aid offices in LA County that can help the client. So we provide warm handoffs with that. And I do want to highlight the service for domestic violence restraining orders. This was something our office did not have experience in, did not even, you know, have ideas of getting into, because we have a legal aid organization that we refer to because they're experts in serving survivors. But because of the needs we were seeing through our data, through the clients we were serving, there, you know, a lot of them needed help with filing restraining orders. So through that, I connected with our legal aid referral office that we kept, you know, giving our clients to. I connected with them, became a part of some projects they had, so that I personally became an expert and developed the knowledge to help clients directly with these restraining orders. So this is another example of, you know, you can start these projects, not be prepared, or, you know, our office did not have any experience in this area, and now we provide this service thanks to this project. So, you know, being flexible, being adaptable is really important. And like I said, you know, as much as I was downplaying the self-rated data, we collected a lot of really interesting points throughout the 2-year term. And so in this project, I served almost 120 families, and we recouped almost $40,000 in economic benefits for our clients. And these economic benefits come from food stamps overpayment appeals, CalWorks appeals, small claims awards, housing programs. So especially during COVID, California State, LA County, LA City had a lot of rental assistance programs that we helped clients access. And then also crime victim relocation assistance program funds for survivors, which our office had no idea existed until we started helping clients with these domestic violence restraining orders. So, you know, now our services have expanded. We're able to help clients on a wider range of issues. 77% of our clients were receiving therapy for mental health, and 14% were affected by COVID. And this means they either contracted COVID, their family did, they lost employment, lost housing. So a broad definition of being affected by the pandemic. And then again, back to these self-rating results. Yes, these clients were reporting this to me, but 95% and up above clients reported that our maternal medical legal partnership improved, you know, their knowledge on different legal topics, their physical and mental health. And not only that, but somewhat improved to definitely improve their access to public benefits, financial stability, housing stability, and family stability. And, you know, I think those words, like just gathering this data, as skewed as it might be, those look good to funders, right? Like they love to see that. They want to know, what did your project do? So again, very important data points to track. And then back to sort of the theory of our project was to ameliorate these social determinants of health and disparate rates that Black and Latina mothers were experiencing in LA County. And our data basically reflected the county data. 14% of my clients reported negative birth outcomes, and all of that entire 14% all identified as Black or Latina pregnant or postpartum people. Additionally, 22% of my clients were dealing with DCFS, the Department of Child and Family Services or Child Welfare Services in our county. And a majority of them identified as Black or Latina families. And, you know, while this data isn't necessarily encouraging, because what you would want to see is, you know, oh, there are no negative birth outcomes, or, you know, there's not high rates of DCFS involvement with our clients, but it's still useful data because, you know, even though we're not reporting improvements, our project can't do that alone. So if anything, this data is reflecting the continued need for this project. So again, all data is good data. You can spin it any way. If it's helpful, you can say you improved. If it's not helpful, you can, you know, argue the continued need for the project. And I also want to highlight 14% of my clients lost custody of their children. And a lot of them lost custody either to their mental health, being considered unfit to parent due to their mental health, and also the failure to protect role. And I can touch on this a little bit more. I don't want to spend too much time, but at least in our county, this rule, basically if any abuse happens in the household and children are present, parental rights and child custody can be taken away from that parent for failing to protect their children. But in the case of our clients who live in studio apartments, for survivors, you know, you can't control when attacks or incidents happen, and your children will always be in the same vicinity as you. So that has really affected a lot of our clients, our low-income clients. And there are advocates in LA County. I've joined a few meetings trying to make the application of this rule more lenient for survivors of domestic violence, because not only does it affect, you know, losing parental rights or losing custody of the children, it's very difficult to regain custody or parental rights. It's not as simple as, you know, getting a restraining order against the abuser. Additionally, the majority of my clients identify as single parents for a myriad of reasons, and 35% identify as domestic violence, intimate partner violence survivors. And again, this percent, 35%, was very important, because if our office didn't adapt and didn't, you know, gain knowledge and expertise on domestic violence restraining orders, that's a huge legal issue area that our project is not serving in. And, you know, we're being less effective for our target population. And so I wanted to pause here and see how your organization collects data. So you've all seen my pre and post intervention surveys. You know, it's very rudimental, self-rated. So please feel free to share how your organization collects data, what important data points you track, especially for pregnant and postpartum population. So I'm really interested, because we're always looking to improve our data collection, because it's so important for obtaining sustained funding.
Courtney, there are some questions in the chat. I don't know if you've had the opportunity to look at them yet, but pertaining to the pre and post survey, how do you capture feeling heard? And if you know what the baseline number would be for lost custody?
Yeah, so capturing feeling heard. So not only are we capturing data, but I don't think I spent too much time on those sheets, but I also write down additional comments that the clients say to me before intervention and after intervention. And a lot of times when I'm closing their case, going through this, I ask them, you know, how do you feel now that I'm going to close your case? Do you feel like okay? Or if you need me to keep it open, let me know. And that's usually their opportunity for them to tell me, you know, thank you for listening to me. Especially for clients with mental health disabilities, most oftentimes when they meet, by the time they meet with me, they've already been given the runarounds, had a lot of doors shut on them with other agencies, other attorneys. So most times, even if I'm unable to help them, if their problem is not a legal issue, a lot of times they cite, you know, thank you for listening to me, I feel heard. And so that's actually just a phrase that we hear often, and I've documented in my case notes. So I think that raises another point, is besides these data collection, like questions and surveys you might administer, capturing the qualitative data is just as important. Data with stories is more powerful than data without stories. And then I see another question about funding for services for undocumented individuals. And so that depends, depending on the legal aid organization, if you partner with one or work through one, depending on the funding that the legal aid organization gets, they can be limited in serving certain clients. For my organization, we are not limited. And specifically, if you get an Equal Justice Works Fellowship funding, what my office will do is sometimes we'll get federal funding that has limitations, and sometimes we'll have funding that does not. So depending on the attorney working under different grants, sometimes you have some leeway in serving undocumented individuals without those limitations. But in my case, we did not have any limitations. The medical program didn't have limitations or citizenship requirements for their patients. So luckily, that wasn't a hurdle that we had to balance.
Courtney, before you move on, I have one last question for you. Is the data shared between partners in the aggregate, and do you know if it's integrated into the health partners' quality improvement plans or other healthcare performance measures?
So right now, it is not. Basically what it is, it's our system as it is right now is very separate. Our medical partners don't share information with us. As far as me giving information back, I always make sure, and this is another note, I know some of you were concerned about like number of clients or patients served or like getting a client referral system going. And so one thing I do is share with providers success stories, or I'll share with them my the data that I do. So I collected data at the 6-month mark, 12-month mark, 18 and then 24-month mark, just to show them like, this is what we're doing. These are the legal areas. These are our clients, just so that they can see who we're serving. At this point, we don't share it, but I know through the countywide MLCP, that's a lot more established, that has more legitimized systems in place. There is sort of an information sharing process that we utilize, but those provider information sheets that we share with the healthcare center are still very generalized. We're not sharing specific information to the referring provider about what we're doing on a client's case. We're just letting them know, yes, we contacted them. Their legal issue is resolved. And this is a challenging thing to balance, because I know our medical providers want to know this information, and attorneys are trying to maintain confidentiality and maintain attorney-client confidentiality. So I think all this are good questions to consider when you draft MOUs, memorandums of understanding with your healthcare partners, to know, how are we going to share data? What types of data do we want to share? So that, for whoever's applying for funding or wanting this information, everyone's on the same page throughout the project. And then I also want to note that the full report with all our client data and resource guide that I created at the end of my fellowship term, I believe should be available in the presentation materials. And it's helpful because I sort of created it in case our fellowship ended and we weren't able to sustain the project. So not only does it have our client data, but it has resources and referrals for common legal issue areas that I worked with my clients, so that the medical providers know, okay, this client has a family law issue. Courtney's not here anymore. That project's over. Here's the list of people I can refer the client to. These are the people I can contact that Courtney knew, that work at this organization. Here are resources for survivors, for housing referrals. I also created fact sheets during my fellowship to talk about food stamps benefits, overpayments, appeals, CalWorks benefits. So I included a lot of information in this resource guide to help not only medical providers, but also other legal advocates that work with similar client populations. It's very California, LA County specific, but I think it's a good example to replicate in other regions, to document what was done in a fellowship. If, you know, in the worst case scenario, it doesn't continue, at least there is still that data. There are still those success stories for whenever, you know, hopefully funding comes again. Okay, and then I have a success story, but I see in the chat about releases to share information, and that is something that we do as well. So even at the mental health medical legal partnership that we're doing here on site at clinics, especially with mental health, a lot of times clients need an advocate or someone to be with them during attorney meetings, which generally for attorney-client privilege, it should only be the attorney and the client. But in cases where it's necessary, we see that as a reasonable accommodation. So, you know, if this client has difficulty expressing what they need or understanding what's going on in their legal situation, we always allow a provider or a family member or friend to sit in on those. And also sometimes providers will let me know the client consented, the client will let me know they consented. So I'll update them on more details about the legal matter, so that they know, especially for their treatment, so that they know what to expect when the client comes in for their next therapy session. Or, you know, if I wasn't able to get the landlord to fix a plumbing issue or a mold issue, the nurse will know, okay, I should definitely still make sure that they come in for the appointment so I can make sure their health is okay. So there are releases and consent forms that can definitely be signed to share more closely the details of information. So I think with medical legal partnerships, everything can be tailored to what both parties, medical and legal, are comfortable with sharing, and then developing a system is the other hurdle to you know, get that to happen.
Courtney, on that note, don't mean to interrupt you. Good morning, my name is Sigolene, and I put a question in the chat. So I know that you were sharing in the custody cases that you've supported parent losing the custody case, but in our case, some of our medical providers will get approached by the patient and say, can you provide me a letter of support that showcases that I'm the parent that's involved in the medical decisions of my child? I'm the one that brings them to all the appointments. Have you seen any case like that in your experience? And are there templates, or what kind of information is helpful in that letter? Or how can we provide that type of guidance to our medical providers?
Yes, that's an amazing question, because I tell clients to do this all the time. So I'm glad to hear from your perspective that it is that it's not something you don't like doing, but it's something that you would like to learn more about. So that's actually a big part of what I do, especially when I'm on site at a clinic or talking to referring providers. Anytime there's a situation, so say a housing situation, or in your case, like the custody situation, letters of support for medical providers are one of the strongest support factors that we consider to really make a difference in hearings for people, because medical providers are accredited. You know, as an attorney, I can say all I want, but I'm their attorney. So of course I'm going to be, you know, promoting them, hyping them up. But as a medical provider, your expertise, your license, your opinion matters a lot to judges and in administrative hearings. And so what I do is I'll let the client know, okay, to prepare for this, you'll want a letter of support. Let your provider know, ask them if they're willing to write you one. And then if they have questions about it, they can talk to me. And I also do this for reasonable accommodation requests. So things like a client wanting to be exempt from a citizenship exam for immigration purposes, you can make reasonable accommodation requests for physical or mental health disabilities. And I'll walk through providers, you know, what information should be included. Typically just explaining the nexus, the connection between a client's disability and their need for the accommodation. You don't have to share diagnosis details or anything like that. So this is a huge part of what we do in the medical legal partnership, is help providers write these letters of support in whatever legal issue they're dealing with, whether it's housing, employment, family battles, and all of that. So there are templates out there. Usually you can look up reasonable accommodation forms. I think that's the best general form to look up, because it's in any sort of medical opinion letter, you should always mention what the client's limitations or accommodation needs are. And then of course, just stamp it with your credentials so that the judge knows this is coming from a verified person, and they've confirmed that their needs, their accommodations, or what they're saying is true. So especially in the context of mental health, when therapists write letters of support for parents in custody or visitation battles, that goes a long way, especially for modification. So say the parent lost parental rights or custody because their mental health was, they were in a crisis at that time. There's a substantial change in circumstances, and that therapist can attest, since then, the client's been getting regular treatment. They're able to take care of themselves. They have a job now. All of that goes a really long way in those types of hearings. Okay, and I'm going to share this success story before we get more into other questions about sustainability. And the sustainability section, I do want to preface, I will be asking you all for the challenges you're facing and what has worked out for you, because like I said, our maternal medical legal partnership is new. We're approaching our 3rd year and piecemealing together small grants. So I would love to hear from you all. And I know you all mentioned that funding challenges and concerns were a huge thing you were looking for out of this learning collaborative. So I do want that to be collaborative, but I'll start off with a success story to illustrate what work our maternal medical legal partnership has done, specifically in the context for mental health. And as a trigger warning, this case does have mentions of domestic violence, intimate partner violence. And this was a case that one of my first few cases as a newly licensed barred attorney. And I think this is one of those cases that will stay with me forever. And it always makes me emotional talking about it. And so one of my clients, we'll call her Jane Doe. She's 21 years old, balancing motherhood, mental health disabilities, and several legal issues all at one time. When I met with her, she had recently gotten out of an abusive relationship. And due to that abusive relationship, she lost custody of her older children. So she was already in child welfare proceedings where they were going to take away her parental rights. And again, this goes back to that failure to protect rule, because the abuse happened in the household, her children were present. And not only were her children now in the child welfare system, but Jane herself grew up in that system. And the social worker for her children in that case was her social worker when she was in the system herself. So that was another issue where, we tried to raise conflict of interest, bias against that social worker, using information about the client when she was younger in the system against her ability to parent and protect her children. So mind you, this was not even the legal issue that the client came in for. She was actually pregnant with a new partner who had been very good to her. Her life was going in a better direction, so she thought, and she was living in an apartment when this landlord unlawfully evicted her, meaning he changed the locks on her, kicked her belongings out without going through proper procedures, proper court procedures, while she was pregnant and during the pandemic. So LA County, the state, LA City had tons of protections. So the landlord made tons of legal violations in doing this. And not only that, but say he illegally evicted her in August. And then a few months later, he sued her for rent for the months of September and October when she was not even in the unit. So the audacity of this landlord was surprising, but not surprising if you work in LA, and I think in any urban area, landlords will do very interesting things. And so the clients had contacted us about that issue, but during the intake, when we do the sort of legal checkup, that's when I learned about all the other legal battles she was going through. And small claims court is kind of like Judge Judy, so attorneys are not allowed. It's just the two parties and the judge. But what we did was we helped her prepare for the small claims hearing. So we drafted the brief for her, citing all the laws that the landlord violated and all the penalties that the landlord owed in a counterclaim document. And then I met with the client several times to help her practice what she would say. The judge would only give her 5 minutes, may not be the most friendly person. So, helped empower her to speak up for herself and, have her voice heard. And the layers of the story are that the client gave birth to her newborn at this time with her new partner. Shortly after, her new partner also became abusive, and during one incident in the household, her new partner went to jail for domestic violence, and she lost custody of her newborn. So not only is she still dealing with maybe losing parental rights of her older children, now she's postpartum, has her baby taken away, and her new partner, her support system, is out of the picture. And then here I am, helping her with a small claims case, which is the least of her urgent issues at that time. And so I think this is very important in the mental health medical legal partnership context. As her attorney, I helped her postpone the small claims court date. That was not her priority. Other things were going on. Her therapist helped her work through the trauma, the ongoing trauma, how to heal and how to keep moving forward. And her nurse helped her get the necessary treatment that she needed after the attack. And the client, just her strength really sticks with me. And after a while, I kept postponing the small claim. She was like, no, I want to do this. I want to get it over with. And I met with her, and she was reading through the brief again, and she started tearing up because she said she knew that everything that happened to her was wrong, but she didn't know how to put it in words, or she didn't believe that the law would be on her side. And so there I am, trying not to cry, my mask, my glasses are fogging up. And she said, after I helped her practice, what to say at the small claims hearing, that one day she hopes to go to law school. And so the client did. She advocated for herself at the small claims hearing, despite all the adversity that is still ongoing in her life. And the landlord, the judge ruled that her tenancy rights were entirely violated. My office was cheering as we read this order from the judge, and the judge awarded her more than $725 for her counterclaims. So the client walked out of this hearing with the landlord owing her money instead of owing the landlord money. So I think this was still my favorite success story, because the client, with her therapist, with her nurse, with myself as part of the team, we helped empower her to move forward with just this little piece of what was going on in her life at that time. And she did get a restraining order against her both partners. We connected her with an intimate partner violence organization to help her get a job, relocates, and to one day regain custody of her children, and then maybe to go to law school one day. Maybe she'll start the next amazing maternal medical legal partnership. And so I love this success story. It's my favorite. And with that, on this high, let's talk about a very not so favorite topic of sustainability. So this is the question on everyone's mind, question on my mind, on how to keep this incredible work going. And as attorneys or as medical providers, it's almost like we're asked to do this amazing work, collect these stories, collect these data, and then still search for funding on the side when we have time. So of course, we know funding, data, success stories are all important to sustain a project, but it's easier said than done. I also wanted to note that a strong MLP working relationship is very important, because in order to get the data, you need the client referrals. So, having these sort of legal trainings with providers to let them know what you can help with, sending them success stories, sending them updates about the client data that you're working with, just so that they remember you're there. And also they remember to refer clients to you, and that they feel comfortable talking to you and not like, oh, should I refer this? Is that wrong? Is this the right way to do it? Just having that strong working relationship. And so I wanted to, hopefully I haven't taken up too much time, to talk about sustainability practices that have worked well for you all, and what you're struggling with funding. And I'll just start it off to say, I mentioned a little before that our maternal medical legal partnership, we're piecemealing funding. So we got a small grant from a LA County supervisor based on our data. So they asked us, okay, based on this geographic area that the supervisor oversees, how many of your clients came from this area? Are you helping my constituents? And so luckily we had that data to provide. We showed them success stories, tried to tug at their heartstrings, and we got a small grant from them. So of course the preferred method is getting one huge grant for multiple years so that you don't have to keep the funding search going. But at least for us, it's been possible. It's now March, our project is still going. We have some grant applications constantly going out into the world. So we're hopeful that the funding will come. And as long as we keep continuing our data practices, our success story practices, it has been working with us so far. And so part of the reason we partnered with the Nurse Family Partnership was knowing that they were a national program. So our hopes were that if we could show that LA County's partnership went well, we could try to get funding through NFP statewide, expand it statewide. Top goal would be to expand it federally at all Nurse Family Partnership programs. But that has been difficult with our medical providers just because their funding has been shifting over the years. So they haven't been in a stable place to, create our services as a line item in their budget. So we're not in any conversations with health plans or any other like healthcare agencies yet, but we've been doing research to apply to anywhere, any place that applies to our maternal client population, and sort of just seeing what sticks. Thank you for sharing that, Clinton. Yeah, I will say it'd be nice to have ongoing funding through these plans, and even our countywide, more established medical legal partnership at health sites and now at mental health clinics. At one point, we were applying for funding every 6 months, and this was a huge program that staffs tons of attorneys across different legal aid offices and across the county. And so applying for funding every 6 months was very, unsettling. Now we're at the point where I think we have funding maybe a year to two at a time, which, is still not ideal, but I'm kind of, as a new attorney, as someone new to the scene, I'm kind of learning that this is just the nature of our work. So if anyone has any tips on, any funding that has shared, that has provided long-term funding, please feel free to share, especially for maternal populations.
Courtney, I'm going to ask, because I know you addressed it, but I just want to read out what Clinton Householder shared in the chat that you were addressing there, and ask Clinton to unmute. Clinton, if you can. I don't know where you are, if you have the ability to unmute, but I think it's really important to talk about this sort of funding strategy, which is not grant-based, but reimbursement or payment based. So Clinton shared in the chat, which Courtney responded to, that they've had success getting the Ohio Department of Medicaid and Managed Care Plans to fund their Pathways Hub MLP work. I think Marie also mentioned this in the chat earlier. But that funding is limited to, sorry, I'm having trouble on Zoom here, but that funding is limited to clients who are pregnant or have children under the age of 1. So it'd be nice to have ongoing funding through the managed care plans, but they've not been able to arrange that as yet. So Clinton, or Marie, anybody in Ohio that's familiar with this, would you mind sharing with folks on here a little bit more about what that work looks like for an MLP to engage, even to the extent that you have been able to, what it's like to engage with the health plans or the Medicaid agency in Ohio, even as you work to expanding that funding. A lot of folks are not there yet, as Courtney acknowledged, and many others are trying to achieve. I'm not sure if I'm having trouble with.
Nope, I'm able to unmute.
Oh, perfect. Thanks, Clinton.
I have very limited understanding of how those conversations first began. If Marie is available, I think she might be better equipped to comment on that. Marie is actually my manager here at Community Legal Aid, but from my understanding, the Ohio Department of Medicaid and the managed care plans decided to fund our MLP work through the hub model, in part because the counties in which we're engaged in this model have such high infant mortality rates comparatively across the state of Ohio. One county is Summit County, Ohio. The major city in that county is Akron. And then the other county in which we do this work is Mahoning County, and the major city there is Youngstown. The infant mortality rates in those counties comparatively across Ohio are much higher than in other regions throughout the state. And they actually have some of the worst numbers in the country, from my understanding. So I think it took several stakeholders coming to the table. As Marie mentioned earlier, the hub is very much a wheel and spoke type program, and legal aid is just one small part of it. They also bring to the table mental health providers, transportation services, church groups. There's a wide range of different spokes that participate in these collaboration hub type models. And I think it took all of them coming together to approach the Ohio Department of Medicaid and the managed care plans to accomplish the funding stream. It's a grant. I think right now it's renewed for a couple years, but at some point, I think it's supposed to become a competitive bid process, and we'll have to prove the success of our project in order to continue to receive funding, particularly from the managed care plans. That's my understanding of it. Marie, I don't know if you're able to unmute and provide any more context.
That's a really good description of it. It's actually money allocated through the Ohio Department of Medicaid. So it's my understanding of it is it's taken from a pot of money that would otherwise go to the managed care companies as bonus money, or performance-based money, but it's used to support these extra services or this infant vitality wraparound, so that the people that are on the managed care plans can be healthier. In Ohio, we just rebid our managed care contracts, and the new contracts are just going into effect, I think, last month. And as part of that rebid, every managed care company is required to set aside a certain amount of resources for addressing social determinants of health. And we haven't seen that explicitly channeled to medical legal partnerships, but that does seem to be an obvious possibility. I'm not sure who is at the table to have that conversation right now, but the medical legal partnership collaboration in Ohio is pretty strong.
We appreciate that, Marie. And I just want to note that the California-based MLPs were embedded into the previous Medicaid 1115 waiver, whole person health, really strong similarly, right? And I just want to note that Ohio MLPers, you all just keep tooting your own horn and loudly, because you want to make sure that in these new conversations, the rebidding, the revision processes, that the health plans as well as the Medicaid agencies know that you all are the SDOH intervention. Some folks are still, in the, I think, screening phase and haven't, and or just cold referrals, but they haven't moved to a fully integrated approach that MLPs are carrying out. That's your strength. You know what the costs are. You know what the savings are. You know what the quality improvements are. This goes back to all the conversations that Courtney was driving through this session on data collection and sharing the tips that she shared. So don't just assume that they will know about you or remember who to talk to. California just went through this, and Courtney's there, right there in LA County, and can talk about that. Thank you, Clinton and Marie.
That's really interesting to me that in California they're doing that as part of an 1115 waiver. So however much they've allocated to that and whatever spaces, does it include, Courtney, your program?
So it does not include my program, to be honest. I don't know too much about California's funding process right now, but I do know that my agency has sort of just been cold applying to grants so far, and we haven't yet. I think just because we're newer, we're a smaller organization, we haven't really mustered up the courage to even consider applying, through these options like you all have done in Ohio. So I think this is definitely an area of growth we can do, and sort of gather, like you were saying, not only approach them with ourselves as mental health advocacy services, but sort of create that hub for ourselves with advocates doing the same work, and transportation providers, medical providers, mental health providers. I think that is something that we have not done with our maternal medical legal partnership.
I'm excited about your pre and post survey. One of the challenges that we have had in all of the 12 years we've existed is, maybe it's even more, is being able to tell the story from a non-legal perspective. Right? We capture the really boring legal interventions, but they don't tell enough of the story to capture the attention of funders, and they don't tell the health story at all, or rarely. So having your medical champion or your healthcare provider being about data collection and assessment and analysis is really just a gift. Really, it's a huge bonus.
Thank you. And I will echo that our executive director at MHOS definitely had to train us as attorneys to write up these success stories with a less legal lens. We want to know about the person, about the story, about the health, aside from just saying, we helped her with a small claims case. So yeah, that was another learning curve that we went through, is learning how to best present what our work was really doing in tandem with medical care. And so Danielle, I don't know if we have too much time. I have other discussion questions if we want to go through those. Otherwise, I can pass it on to you to close out this session.
I think we have time for maybe one. Some like number 3, I think we've addressed shortly. But I think either number 1 or number 2, if anybody would like to unmute and share, we have a little bit of time to discuss one of those. And I think on the next slide, and these the slide deck will also be shared with everyone, but people will see your email in the deck, and they can also reach out if they have further questions for you.
Sure. Yeah, and one thing with this question number 1, if anyone, I'm really curious to know, because we're across the country, everyone on this meeting, what sort of regional needs are you seeing with your maternal population? So in LA County, housing, immigration questions are always big, but I wonder if there's any unique things that you're seeing with your client population that have been areas of concern.
I'm happy to share. I know that Henry, director of the Watsonville Law Center, is also here with me. I'm with Salud para la Gente, and it's a small FQHC that primarily serves the South County part of Santa Cruz County. And our patients tend to be immigrant agricultural workers with limited English capacity. And a lot of them speak indigenous languages like Mixteco. So a lot of the need is even support with having Mixteco interpreter to be able to support them and connect them with paid family leave, SDI, paperwork, other things that we're concerned with our patient population is exposure to pesticides. And so we're working and through our legal medical partnership with the Watsonville Law Center to really look at ways that we can support the population by, and I know that a lot of advocacy goes into even getting a medical diagnosis with EDD, right, to recognize it as a disability. So really kudos to our medical partner that's on this call as well with meeting that need. And we're still working on that as well. So just sharing.
Thank you so much, Sigolin. Marie, if you want to quickly offer your thought on number 2, please feel free to unmute.
One of the things that we have started doing just in the last maybe 18, well, maybe not even 18 months is, and this will make some people uncomfortable, meeting with our community partner, and we have community partners in and out of health systems once a month to update them on what's going on in the cases that they've referred, in the families or the patients that they've referred to us. And this is why I was asking Courtney about the release of information. And what that has done for us is and we get a release from everybody, you know, before we talk to anybody. It's allowed us to make sure that the cases keep moving forward, because a lot of our cases get pushed out to other lawyers in the firm, and they're not, it's not that they haven't drunk the Kool-Aid, but they're not public health people. They're not embedded in the model in the way that the people that like Clinton and I are. And so it helps them to keep the MLP cases as important as their other cases, because sometimes the MLP cases are not as big a crisis, and so they're not on fire, and so they don't get the attention that others would get. And so having to report to our community partner every month kind of balances that out. But it's a ton of work to do that, to put that together every month. And, you know, and Clinton and I go to like community healthcare worker meetings, and we go to supervisor community healthcare worker meetings, and we go to grant partner meetings for Ohio Department of Medicaid. And so we spend a lot of time, you know, not providing legal services. That's also a struggle for many lawyers. So I will be quiet now.
Thank you so much, Marie. Thank you, everyone. Thank you, Courtney, for leading our session today and for such an engaging and rich discussion. Again, in the slides, you'll find Courtney's email. So, and also in the welcome packet, we shared all participants' emails. So if you want to connect, please look at those. We do have a very brief survey about today's event that I invite you all to participate in. You can either take a photo of the QR code that you will see on the screen shortly. Rhea, if you can quickly put that up, that would be awesome. And the link was also shared with you in the chat by our team. It won't take very long to complete, but really helps us understand your learning and technical assistance needs and also help us improve. I also want to mention ahead of time that there will also be a 3-month post-event survey that will go out around June to understand a little bit more about how you're able to apply the learnings here you received here at your different organizations. So look out for that as well in the coming months. Again, thank you everyone.